Welcome to this introductory podcast for Knowing Your Way, a Princess Margaret podcast series for people affected by ovarian cancer. My name is Dr. Alicia Sarabia. I've been a patient of the Gynecologic Oncology Program at the Princess Margaret Cancer Centre for 7 years now. My guest today is Dr. Marcus Bernardini. He is the head of the Division of Gynecologic Oncology at Princess Margaret and associate professor of the Department of Obstetrics and Gynecology at the University of Toronto. Thanks, Dr. Bernardini, for being with us today.
My pleasure. Thank you for the invite.
The purpose of this podcast is basically to introduce you to the Knowing Your Way podcast series and also to orient patients a little bit more to the system in which they're finding themselves in. That is the Comprehensive Ovarian Tumours Program at Princess Margaret. I'll start off by telling you a little bit about myself, and then we'll have a discussion about the program itself, which will include Dr. Bernardini, of course. I've been a patient with the program since 2015. I first met Dr. Bernardini and his medical team at Princess Margaret after I'd undergone an ultrasound, which showed what was likely to be a tumor involving my lower abdomen. I had become aware of a fullness in that area, had gone on to have the ultrasound, and I was then referred to the team at Princess Margaret. A few weeks later, I underwent surgery, and I was thankfully back home in time for Christmas and New Year's. Subsequently, after a couple of setbacks, I started chemotherapy. And the chemotherapy was received by way of an intravenous line in my left arm and also into my abdomen via a device that was placed into my tummy or abdomen just below the area of the right ribs. After this form of chemotherapy was completed, I went back to work. I recovered from both the cancer and the chemo, and I did fairly well until later in 2019. At that point, some lab tests and a CT scan showed that the cancer had returned. And so I was started on chemotherapy once again, this time by the intravenous route only. And afterwards, Dr. Bernardini felt that it would be a good idea for us to consider a different type of chemotherapy drug called olaparib. Olaparib is a drug that you take by mouth twice a day. And this is what I've been doing basically for almost 2 years now. And I've been doing fairly well, I'm happy to report, with a fairly stable health status. And so that's my story. A little bit about the podcast inception and why we thought it would be a good idea. Well, prior to 2019, I had just been working in a hospital as a medical doctor, taking care sometimes of patients with ovarian cancer. And the women that were admitted to hospital were fairly ill. They had been admitted to hospital because they had complications of the cancer or the treatment for the cancer. And so my perspective of what ovarian cancer was fairly skewed to these very ill people. I didn't know anyone personally who was living a life with cancer free from complications. And so obviously from the time of my diagnosis, I had a lot to learn, and I have learned a lot, and there's much more for me to find out. One night, my husband and I were talking, and he thought that it might be a good idea for me to share my experiences, to share my learnings with a broader group of women with ovarian cancer, with their families, and with any interested friends that wanted to support them along the way. He thought that a podcast might be a good idea. And so I approached Dr. Bernardini and his team, and they supported me in this idea, and in fact have been very active in helping us with the podcast itself. So here we are introducing you to the first of the series. We hope that the podcast will help you by providing you with knowledge, with some comfort, maybe even some companionship. I just wanted to add that while this cancer has not defined me entirely, I'm definitely not the same person that I was back in 2015. Ovarian cancer is a serious illness. It can sometimes even be life-threatening. And so really, this diagnosis has shaken my world and the world of the people that I know and that I love. But I do feel that I'm very well supported. And I am grateful to the team at Princess Margaret Cancer Centre for that. But I also want you to know that I understand how you are feeling as a listener who has either received a recent diagnosis of ovarian cancer, or if you are a listener who knows someone that has. I understand you, and I know what it is that you're going through. So with that, Dr. Bernardini, I think I'd like to introduce you so that you can tell us about the program that you and your team have been developing in order to best serve the needs of listeners that are signed on to this podcast.
Yeah, absolutely. And again, thank you again for spearheading this initiative. As I hear your story, and obviously at some level a very good story many years after the initial diagnosis.
Yes.
One of the things that comes to mind is that everybody's story is probably slightly different in their own way, with their own knowledge coming into a situation, their own past life experiences, some of the other things that may be going on in their life at the same time of having a diagnosis like this. But I think there is one common element, and that's why I think this is such an important endeavor that you've taken on here, because the amount of information and the amount of things that come at an individual, especially in the early phases of this diagnosis of this disease, are enormous. And I think that it doesn't matter who the individual is. It causes a definite imbalance in their world as they know it. And then you're having to deal with really the medical elements, the mental elements, all of these factors. Yeah. And so, I think this really was partially at the core of how and why we developed this program. Ovarian cancer management has a strong reputation at Princess Margaret for years. I was fortunate to, in some ways, grow up within that system, and did training along the way, and very, very honored to join the team. But as we always tried to improve, these are the kind of things that we put together and said, we've done a lot, but we've got a lot of work to do. And so the creation of this program is really centered around three pillars. And I think the first one is the one that you are alluding to in your initial introduction. And that's it. That is that we really felt that we wanted to provide support for patients and their families right at the introduction to Princess Margaret, so to speak. Right. And we define that as patient navigation, if you will, and sort of navigating the individual, navigating them and their family through all of these things that for them will be the first time they've experienced anything like that. But for us, because of our knowledge and expertise, can help them to interpret and help them to cope with some of these early findings. And so, and that was the creation of the nurse navigator. So any new patient that enters the program at Princess Margaret now has a one-on-one with this individual. Okay. As you look back, you may think, well, that would have been nice because that wasn't available back when you had your diagnosis. But again, hearing you speak, I think it really touches on those points that I think that this individual really helps people with. And we've had some very positive feedback.
Absolutely. I can imagine. Yeah. Yeah.
And so the second part, obviously, is to establish a robust research program. Again, Princess Margaret has a long history of important research in gynecologic malignancies, like other cancers. But we really felt that it was important to establish a platform for which the individuals can be offered research that they may or may not want to participate in, and stay really at the forefront of the management of this disease. And so we really put a lot of energy around that.
So, Dr. Bernardini, what do you mean by offering research?
So I think, when we think of research initiatives, historically, you might think of a particular study, or you might, obviously, you'd think of new medications studies or these kind of things, and those are pretty well established. But I think there are subtle things in terms of how we can do things better, in terms of even things like communication or accessing genetic information. These are things that historically we've tried to implement within our healthcare system, but haven't necessarily had the opportunity to ask poignant questions in certain ways from the patient perspective. And again, I think having a platform like this allows that opportunity.
Yeah, you're giving me that idea that should be probably a topic for another podcast, is all the research that's going on and what you're planning and how patients can get involved.
Yeah, absolutely. I think, it should be looked at as the patient is part of the process, not just sort of, would you consider being, there's an experimental arm of treatment or something. And so I think that's something that we're looking into and trying to expand. And the third part is around data acquisition. One of the challenges in medicine in general is, and you're obviously familiar with your expertise and your training, that the amount of knowledge that can be obtained is really dependent on how closely you're looking. And over years, over time, there has been an increase in precision. And that includes obviously diagnostic things that have improved compared to, 30 years ago. Someone's able to have a lot more information about, for example, even where their tumor is located and such. And so data collection in medicine is very challenging because it requires someone to stay on top of it. You run the risk when you collect data retrospectively, meaning going back into charts and files, that you're not getting clean data. We know that that's a big problem in medicine. And so this has created a platform for us to make sure we have up-to-date, accurate information that will then inform us moving forward. And to give you an example of that in terms of data collection, we have implemented something in our institution where when someone has an operation for ovarian cancer, historically, the description of the disease was based on what the doctor would report. If you go back 20 years, it was not that informative and very crude. Over the last 10 to 20 years, things like synoptic reporting, which means you actually have to report on certain things, has improved some of the accuracy, but it's still somewhat crude. And in a disease like ovarian cancer, that is very complex as a combination of surgical management and chemotherapy, the more information we can get about what these cancer cells even visibly look like, the more important it's going to be for us to guide management moving forward. So all patients at Princess Margaret, when we do surgery, it's very much akin to, if you go for a colonoscopy now, it's very common that your doctor will show you a picture. Let's say if there's a polyp or something, they'll give you and say, here is the polyp that you had. And we are doing the same thing for ovarian cancer surgical procedures, so that we'll have images to see what these cancers actually look like inside the body. So that's just an example of the kind of data that we are collecting, which we think will put us in a real good position moving forward to shape the field.
Great. That sounds very, very interesting. I'm glad that the podcast ties into the first of your three. So that's the patient navigation and support in the program. And then secondly, you talked about the value of research at Princess Margaret. And then finally, how to collect information about the patient population that you take care of so that it will help patients in the future, as well as, I guess, your efforts in research. Is that right?
Yeah, absolutely. And I think, to the first point, and again, this is why I think this podcast series is really so great. There's no question where we can do better. Where, in my opinion, we haven't focused enough energy and attention over the years, is the patient experience. We are in Canada in general, I think for the most part, excellent at the actual medical elements of it and providing good, sound care and advice. But where I think we're lacking is it really around that patient experience and that patient journey. And, when you think of quote unquote customer service in a way, we think of other elements of our society, and a lot of it is around that. I think in medicine, we probably could have done and could do better. And again, I think these kind of series really, I think hopefully will resonate with individuals and patients and see that it's very helpful.
I think so too. So while we're on that topic, then this podcast, I know, is just part of what is being done in order to improve the patient experience. And previously, you mentioned the nurse navigator. Can you tell us a little bit more about the nurse navigator, the program coordinator, and any other key people in the team so that patients and families listening to this know who it is they're talking to and what that person's role is?
Yes, absolutely. So the nurse navigator role individual, as soon as someone gets a referral to our center, they're going to get a phone call from this individual. Okay. Currently, Mary Chris, one of our great nurses, is the individual who does that. And so right away, there's an introductory phone call where she essentially introduces herself and lets the individual know that there's a number of things that are going to happen over the next few weeks. I'm here for you. I'm here to help navigate those things, help to explain them to you. She's present when they have their first visit, when they come into the clinic, so they can then get to know her in that capacity. And she really stays with them in that early phase of treatment, from chemotherapy to surgery. And again, it's someone that these patients get very comfortable with, and is someone that they can turn to. And so that I think, and we've so far received some very, very positive testimonials around that. Tara Almasi is our coordinator, our program coordinator, because one of the things that we have realized, going back to some of the things we talked about earlier, is that we've now opened up a Pandora's box, if you will, and there are so many things that we can do to improve the patient journey. We're working, for example, right now in the early phases of an app, again, that can help individuals from a knowledge perspective, but also helping them, guide them along the way. There are initiatives around getting educational materials out there. We're working on videos for patients. We're always trying to optimize, for example, things like time to chemotherapy, time to surgery. So it's really quite encompassing, and Tara oversees all of that and keeps us in check, and also helps to manage that data portion that we talked about to make sure that we're doing that accurately. And then we have a research.
It's a big job. And just because you've mentioned Tara, I'd just like to give a shout out to her, because she's been as much a part of this podcast as I have been. She's been doing a great job getting things going.
Yeah, no, absolutely. I mean, I think Tara's an invaluable member of our team. She has put her heart and soul into the program, I would say, and programs are as good as the people involved in them in many circumstances, and she's a great asset to the team. So yes, a major shout out to Tara. And we also, as part of the program, we're able to hire a dedicated research coordinator that again oversees the research elements with regards to that. And currently Sharon Collins is taking that role. But again, I think by having these individuals as team members, they really help us to move things forward. And then of course, the nursing team at Princess Margaret, as well as the physicians at Princess Margaret as well, are all a part of it as well.
Sure, great. So can you tell us how many physicians form your team?
Yeah, so as of July 2022, we're going to be 8. So that's a large group. It's the largest gynecologic oncology group in Canada, and we have people with various expertise within that group. Okay. We all do the core business, but we've also established niche areas for less common cancers, and so. Again, I think it is a large group. Ovarian cancer remains an important element for all members of the group, and so they're all part of this program in some capacity.
All right. So each of the 8 doctors all have expertise in ovarian cancer, with some of them having special expertise and perhaps less common cancers. Is that right?
Correct. Yeah. And okay. That's what we've been able to establish. I think, when you have a larger group, you're able to do that. If the group is small, that becomes more challenging. So, yeah, I think it's been an advantage for having our group and the size of this. Yeah.
Can imagine. And I know that I saw an awful lot of you when I was an inpatient after my surgery those years ago, and I'm glad to hear that there are more physicians that would be supporting you. I guess that also means that patients in hospital, perhaps even the clinic, might see different doctors along the way. Is that what one of the outcomes might be of this also? Just to let listeners know that they might be exposed to different physicians.
Yeah, I mean, I think we try as much as possible for that initial interaction, the physician that the patient may meet at that first visit, be their person, be the person who's in charge of the care moving forward. Okay. Invariably, during the course of chemotherapy or some other treatments, that individual may be away, or so there may be scenarios where you would meet one of the other physicians as part of the team. Okay. Because we have made it a priority to get people into the operating room in an expedited fashion once this diagnosis has been made. COVID, for example, created quite a problem with operating room time in general. And I would say during the last couple of years, we have had situations more so than in the past where someone may have seen somebody initially, but then their operation and moving forward, they would be with one of the other team members. Okay. And again, I think that, the way that we look at this situation, and I was at a recent leadership meeting in terms of healthcare, and the concept that they thought should be the case, and I think that's a reasonable expectation, is akin to, when you're flying on an airplane and you get on the plane and you see the pilot and you look over and they seem like they know what they're doing, and then you get a message that, that team's actually been on too long of a shift, there was a delay, so the new team coming on, that you wouldn't say, oh, I don't like this new pilot, I like that other pilot, I'm not feeling as comfortable, because you have complete confidence that both of them are able to and knowledgeable and able to do the job to the maximum of the capacity. And that's really how we see ourselves on this team, that a patient should feel comfortable with whoever that they have.
Right. Okay. And then speaking of varying personnel, could you touch on the learners that might might visit patients, see patients along the way. They're called residents or fellows.
Yeah, for sure. So that's, thank you for bringing that up. Because we are what is considered an academic center. So for people who may not be familiar, there are different type of hospital settings. There are those that are called academic centers, and there are those that we use the term community centers. Obviously, first and foremost in healthcare delivery is the delivery of the medical care. And so all hospitals in Ontario partake in that. Well, not just Ontario, but all over Canada and the world. And then there are certain hospitals that have, I would in some ways describe it as added responsibilities. The one that is first and foremost is around training of new physicians and they're usually affiliated with a medical school. And in our case, obviously affiliated with the University of Toronto Medical School. And I think the two come hand in hand, that also these are centers that then would organically be involved more in research and moving things forward. So these are described as academic centers. And so what that means is that there are usually large teams of individuals looking after you, not just the physician and the nursing team, but as you say, different levels of trainees. So at our institution, patients may see medical students, they may see interns, which are full-fledged doctors, but at the early stage of their residency training. Then you have residents who are specializing. And in our case, we have residents in the obstetrics and gynecology program that rotate through our oncology team. And then really the top of our training tree, if you will, are the fellows, the clinical fellows. So these are Royals Board certified obstetrics and gynecology doctors that have wanted to do extra training in oncology. And we have a 3-year fellowship program here at the University of Toronto. And these individuals are part of that program. And in some ways are the leaders of the educational team. And I think, yeah, sorry, go ahead.
Sorry, go on.
No, I was just simply going to say for patients to be aware that all members of the team have defined roles within their capabilities and capacity. So no one should ever feel that someone is overstepping that bound of comfort, that they're not doing something that they should be doing within that level.
Yeah, okay. That's what I was going to ask you about, is how, if I see, let's say I'm admitted to the hospital or I'm in a clinic, and if I see a resident or a fellow, how does that trainee communicate with you, for example, so that I know that, that everyone along that tree, as you described it, is informed of where I'm at with the care I'm receiving?
Yeah, so ultimately, the physician in charge approves every decision that is being made or every interaction. So for a patient to know if they've seen a resident on a particular occasion, for example, and they didn't see their physician on that visit for whatever reason, they absolutely should be comforted to know that that physician is well aware of that interaction, and any decisions being made are being approved or guided by that physician.
Okay. And so we've spoken about the physicians, and you've told us about the key figures of the team in terms of the patient navigator, the program coordinator, and the research coordinator. In terms of accessing the, I guess, the nurse coordinator, patients, I'm sure it's made obvious to them when they become part of the program that they will have various ways of interacting with the nurse navigator, for example. Is that right?
Yeah. So typically, what happens, we have a centralized referral process to the Princess Margaret Cancer Centre, Gynecologic Oncology Group. People with this diagnosis can come from various streams. They can come from their primary care doctor that has been following them for a long time and now have developed some signs and symptoms which are concerning for ovarian cancer. They may come from a gynecologist who was seeing them for a particular reason and also make that referral. They may come from the emergency department, meaning that the individual had a particular problem that landed them into the emergency department, and that doctor has made the referral to us. And sometimes it comes from a different specialist from a different area in the body that just so happens that they come across these types of cases and feel this is ovarian cancer and then make the referrals to us. So those will generally come through a central referral. And then at that point, once they come into our box, so to speak, right away they are flagged for the ovarian program. Anybody that has anything that resembles an ovarian cancer would be part of that program. And then, as I said, Mary Chris would contact them immediately. So, and we try to make that within, let's say, 1 or 2 days from the receipt of the referral. I think one thing that patients maybe listening to this may sort of wonder, how does one, is there a choice, for example, often in our healthcare system where patients go for care, in many ways is dictated by who they have been referred to, again, either by their primary care doctor or their specialist. And I think that, I mean, patients do have a choice on where they can go. And they can inform their doctors to say, I prefer to go to one center versus another.
That's interesting and important to bring up. Yeah. I
think it's an important thing for people to know. And obviously in the context of our healthcare system, again, going back to what I said earlier, the objective would be that it doesn't matter where you're being treated, which hospital, where you are in the province, that everything should be at a certain level, above a certain bar. And I think that that is true. And I think that's important. But I think it's also important to say that our single payer healthcare system should not eliminate the right of an individual to choose care in one center or another. I think that's an important distinction. We have these conversations within our own, medical groups all the time. And certainly there is rationale for certain patients to be referred to certain places over others. But I don't think we've ever reached the point to say that autonomy from the patient's perspective, meaning that their own choice is eliminated as part of the process.
Right. Okay. Thank you for making that point. All right. Is there anything else that you'd like to add for our listeners?
Yeah, listen, I think as much as even from the listener's point of view and from patients or family members or whoever might be listening to this podcast, I too am eager to listen to all the episodes because I think by doing so, I think there are things that as clinicians we learn. I think this is a format that allows people to speak in a manner that they wouldn't necessarily speak to us, let's say in our clinic setting or in the environment. And I think that, again, as we try to really get to the heart of what patients need as part of their care, I'm really looking forward to it, and I think it's great.
Great. Well, thank you for giving me the opportunity to help you with this, and I'm really excited to roll these out and to continue to create more of them along with Tara Almasi. So with that, I think we'll bring this podcast to a conclusion. And also, though, notify our listeners that they should listen to a couple of other podcasts that we've already developed. One is breaking news of a new diagnosis to family members, and the second is dealing with the emotional kind of fallout that occurs, after a new diagnosis as well. They might be quite relevant for people that are listening to this podcast in particular. So thank you very much once again, and we'll see you next time.
Thank you. Thank you.